So I'm joined now by Drs. Craig Miller and Steve Bolling. Thank you guys for joining us. So we're going to start out with a small issue. And we only have a few minutes for this interview, but what are the major issues that you see today in mitral valve repair? Craig?
Number one, Randy, I see a field which is very popular. The patients are demanding it. Everybody's marketing it. But it's done probably poorly around the United States and maybe around the world because most surgeons do and see so few mitral valve cases a year. This is not something, and this course is a good example. You can see the experts make some very complex stuff look easy. And then the danger is that these surgeons who see a few mitrals a year, 5 is the average number per year.
Right, that's what Steve found out now.
Go home and try it at home. And that is not going to work well. So the durability of the repair is key in the patient's welfare, and I am afraid that's being sacrificed because so many people with limited experience are trying to do it.
So Steve, he made reference to the data. We've seemed like we've got a lot of surgeons doing a few operations, and it really is durability. How do we approach that problem?
Well, I think that's a good question. I mean, really the median number of mitral valve surgeries per surgeon per year in the United States is 5. That's not very many, and there's of course a wide spectrum.
Replacement or repair.
Right.
So is it also replacement?
Yes, both.
So the overall repair rate in the United States, the true repair rate is somewhere below 50%, and the population is not being well served by that. I think some of the solutions for that will come in quality auditing of our work. And Craig made a very good point, is that repair rate just means that we did a repair. It doesn't mean that it lasted long term for the patient, or even if it was a good repair.
Or even if it should have been repaired.
Or even if it should have been repaired. And I think these things have to be audited long term. But I think we'll also see, somewhat like the European model, we'll see regionalization of services for complex valve repair. There are plenty of mitral valves, I think, that can be repaired almost by everyone, and then there are some valve repairs that should be referred to a center of excellence.
Well, now you're raising a whole bunch of complex issues, politically and economic issues. So how do you, let me ask you this, let's flip it and say, if we do have qualitative data, how do we get the patient engaged in this conversation? How does the patient say, I want to go to Dr. X because he does great stuff?
Okay, number one, that'll probably fail. Because if you look at public reporting states where the coronary bypass mortality rate is public, and they know the results, the most powerful predictor of where the patient's going to go is zip code, not mortality rate.
Interesting. So they're going to stay close to home.
They're going to stay. They want their support system and their family, and that may not be in their best interest. If we legislate, and only the payers can do this, and Medicare is the payer of last resort for the elderly in this country, and if Medicare doesn't sober up and do it, then nobody will. But the blues will follow.
I think
to insist on quality as the NHS model, which Steve just alluded to, where you have to do at least 25 mitral valve repairs a year as surgeon. Your unit must do at least 50 a year, your hospital. And all of us have our 1-year echoes graded by a core lab, and then we can talk about quality.
So you think that's reachable? Are they doing this?
They're doing that in the UK, and they're trying to float a trial balloon in Europe.
So I think, as we know, payment has always driven practice. And I think that is going to change. We will see a sea change in medicine, how we practice it. And payment will be linked with quality somehow. I think it's going to be hard to do. But I think that will have a sea change in how we look at mitral valve surgery.
Okay. Go ahead.
As we enter the ACO era, Accountable Care Organization, we are all going to feel like Canadian physicians. Let's face it. And whether that penetrates 25% of the market, 50, 75% of the market, nobody can predict. But we will have a fixed budget within each area, and we and the hospitals and the docs are going to have to figure out how we're going to spend a fixed amount of money. And that's going to have a big bearing here. There's nothing more cost ineffective than a halfway good Band-Aid repair that has to be redone or a replacement a few years later, and that's what the patients have to avoid.
I mean, Randy, I think the bottom line is who will benefit from this change in practice that we have is the patients.
Right.
I mean, yes, the practitioners, cardiologists are going to have to be smart about where to send particular patients. We're going to have to be very smart about how to repair, who to repair, and when to repair. But the person who really is going to benefit the most from this are the patients.
So, Steve, I mean, you're, you're exactly right. But you know, after I spend a lot of time talking to a patient, then they want to say, well, can I go to that guy that does it through through my left ear or do a small hole? I don't want one of those. I don't want somebody cracking my chest open. So how do you get the quality answer out?
So patients ask me that all the time, and I tell them I don't care. You can go front, side, back, up, down, robot, no robot, and so on, as long as you get a quality result. And that's what a system of audits or quality assurance or benchmarks or milestones will ensure. It doesn't really matter how a surgeon gets a patient to that point.
So is the quality result coming from the payers?
The payers are the only ones who can enforce it. There's no teeth on this shark unless the payers demand it.
Okay.
Volume criteria, outcome criteria, and it's not whether or not we repair it, it's the 1-year echo result, the 5-year echo result.
No, you're exactly right.
And that's where we have no idea if any of us are any good or not.
So what's the cardiologist who's got Dr. Bolling as the cardiac surgeon who bails him out in the middle of the night when his angioplasty fails, but he's not very good, he's not very good at mitral valve repair. What's he do? So you see what I'm saying?
I mean, that's a very
if I need to send him to Steve Bolling or Craig.
That is going to be a cultural change, that it's going to be an educational effort, not just of us surgeons, but of the cardiologists to realize that change. You can imagine the scenario of 25 years ago when you sent me a case and I did not use a mammary artery. Well, I was your buddy and we golfed together, but that changed. And this will change in terms of mitral surgery as well.
And I think as the solo practitioner or the multi-specialty group cardiologist is almost an extinct species.
Absolutely.
Now. They're all joining healthcare systems. So as the systems get bigger and regional, it will behoove them to regionalize, consolidate this or that, not just mitral valve repair.
Yeah,
but
the concept of a heart team is actually going to have to function.
It'll have to be a regional heart team within a healthcare system. And that's
an interesting
the thing
deal.
that will survive an ACO era, where there's a fixed pot of money.
I think we're already seeing, in terms of cardiac surgical practices, them becoming bigger and bigger, and it allows us as practitioners to focus down on a particular area of expertise. 25 years ago, we separated between pediatric and adult cardiac surgery, and we would never do both, even though we did at one time. I think you'll see separate specialties of mitral valve surgeons and LVAD surgeons and transplant and so on.
Aortic root surgeons. It's got to happen.
No, I think you're exactly right.
Because again, who benefits from that?
The patient. So let me ask you a final question. Craig, you were president of the AATS in 2008, and Steve, you've been very active in education. This Mitral Conclave, we're looking down, we got 1,000 people in the audience. This is a good deal, a good way to educate people.
This is a great way to educate surgeons, unless they go home and try it at home and think they're Steve Bolling or David Adams, and then it's not going to work out to the patient's best interest.
I think this is a great way to raise the bar for all of us, but I think we're going to have a culture change in terms of referrals and payments and how we think about regionalization to really make
how we
the
define quality and outcomes and cost effectiveness 10 years down the road of therapy.
It's going to be demanded, is that correct, do you think?
It will be legislative.
Legislative.
No
It will be demanded
civilization
because that's what they will pay for.
So are you and I going to be with a walker in a nursing home when this happens, or you think it's going to happen in our lifetime?
I think this is going to happen.
The tsunami is coming.
Okay, tsunami is coming.
I don't know when it's going to hit our beaches.
All right. Well, I'm glad we're on the second floor. So thank you guys for joining me.
Thank you.
Very good. Lots of fun. Thanks very much.
He's a pro at this, isn't he?